and I also have the honor to introduce a very eminent speaker who I know from a long, I think around 15 years, Professor Mick. A big welcome to you in Egypt, and we have the honor to introduce Professor Mick Kumwenda, coming from the United Kingdom. He is Director of the Renal Services at Clare Hospital, and he is the Consultant of Nephrology at the University of Health Board, and also he is one of the very distinguished personnel all over the world about kidney disease, and we're very happy and very honored to have you, sir, in this cardiometabolic forum sponsored by Sanofi, and I think you did have a long history for looking for the role of the kidney in glucose metabolism and management of end-stage kidney disease to people with diabetes. Your presentation, of course, will be hypercholesterolemia, focus on PCSK9 inhibitors, and we do have the honor to introduce you and welcome you in Egypt.
Thank you so much for the kind invitations, chairpersons. Ladies and gentlemen, good afternoon. I wish to thank ASD for giving me the opportunity to take part in the Congress in Cairo again. And I'm focusing on protein converters subtilisin casein type 9 inhibitors, which I will call PCSK9 inhibitors to make it short. So far we got human monoclonal antibodies. These listed here, the three of them, they block the action of PCSK9, and then there is inclisiran, which blocks the synthesis of PCSK9. To all of these then to reduce the amount of loss of LDL receptor degradation. So PCA reduces circulating LDL receptor at the hepatocyte cell surface. And the two pictures are showing you what's happening at cellular level, and this is a schematic simplification just to make it a little bit clearer what goes on. So in normal terms, you have the LDL receptor picking up LDL in circulation, and this then produces endosomes, and then the LDL receptor gets split up, and the LDL receptor then goes back to the surface to pick up more LDL, that way reducing the amount of LDL in circulation. The PCSK9 blocks the receptor and degrades it so that the LDL receptor is no longer available for circulation. So if you can imagine that the PCSK inhibitors will block then the action of the PCSK9 product. And then if you look at the other mechanism, which is the inclisiran, is a small interfering RNA targeting the mRNA that encodes for the PCSK9 through gene silencing. This increases the LDL receptors on the surface of the hepatocytes, and that again, like I said earlier on, if that is increased, then that clears up the LDL from circulation. If you focus on the right-hand side, because I don't think the pointer is working, you will see that the action of the inclisiran, in stage 1, it binds to the ASGPR receptor, and that produces the endosome, which is then degraded to release the small interfering RNA, and that is then bound to RISC in stage 3, and then it blocks the PCSK9 MRA and reduces synthesis of PCSK9 in the cell. So, what about efficacy for this group of drugs? So these are the PCSK9 inhibitors. These are very old studies. They were the original studies on the Odyssey long-term phase 3 study, which was aliquirumab to randomize to doses of 75 increasing to 150 milligrams every 2 weeks. And 300 milligrams in some patients monthly. And you can see a significant reduction of LDL to around 60%. And then this was sustained throughout the study of around 48 months. Then they randomized aliquirumab to patients with cardiovascular disease and followed them up for approximately 30 weeks, and you can see in the right side graph the separation between placebo and intervention was significant. There was an absolute risk reduction of 1.25. Similarly, the similar study was done with evolocumab. In this case, they randomized patients in the efficacy studies, and you can see reduction of LDL, again, around about 60% reduction, and then they followed up by the outcome study, which was randomizing evolocumab versus placebo, and again you can see significant reduction of MACE at the end of the study. More recently, they've taken aliquirumab, added them to high-risk intensive therapy patients who have coronary atherosclerosis with an acute myocardial infarction. They randomized 300 patients, 148 had aliquirumab versus 152 who had placebo. And you can see at the right-hand side of the slide, you can see the significant reduction of LDL, again to around 60%. But they also looked at the coronary arteries using intravenous ultrasound and to look at the atheroma volume, and you can see in the aliquirumab group, there was a 2.1% absolute reduction in the atheroma volume compared to 0.9% in the placebo group. Similar studies have been done with patients in high risk of cardiovascular disease with evolocumab. And again, you can see here patients randomized to 140 milligrams per week or 420 milligrams per month. You can see there was a 61% reduction of LDL cholesterol, 18% major coronary events, 23% need for additional PCI, 24% PCI at de novo lesions, and a 24% reduction of PCI at previous stents and grafted vessels. Similar studies for efficacy have been shown with inclisiran, but in this particular case, they randomized the patients, they put the patients that some had diabetes and others didn't have diabetes. Again, you can see there was an LDL reduction ranging from 28 to 52% without diabetes, and the group of diabetes also shows a reduction of 28% to 55% LDL. And they also measured levels of ApoB, non-HDL cholesterol, lipoprotein A, which were significantly reduced, and there was an increase in HDL cholesterol. And at the moment, we are still waiting for studies where they can show the impact of inclisiran on cardiovascular events. The third PCSK9 inhibitor is bocozimab. Again, they randomized patients, 27,000 to bocozimab versus placebo, but this study was terminated at 10 months because the patients developed antibodies against the drug, and therefore it was seen that it was not effective. So the study was terminated. In terms of efficacy, this is a study published from Italy. They developed a registry for the use of PCSK9 inhibitors, and they were using both evolumab and can't say that one, both agents, and you can see a median follow-up of 19 months, there was 64% of the patients achieved LDL target for their CV risk class, and you can see that the adherence and persistence of using the drug was significantly high in at least between 95 and 97%. So their conclusion was that PCSK9 inhibitors are safe and effective in clinical practice, leading to a very adherence and persistence to therapy and achievement of recommended LDL target in most patients, especially when used in combination therapy. The cost is here. You can see that PCSK9 inhibitors are $100 more expensive than ezetimibe, and starting at $50, and bempedoic acid at $800. And therefore, for the indications in the UK are very strict, that for severe, we can only use for primary prevention, severe primary hypercholesterolemia with LDL above 100 milligrams per deciliter, despite maximum doses of statin and non-statin therapies or intolerant to statins. And for secondary prevention, then it's patients at very high risk with cardiovascular disease with LDL above 70 or non-HDL above 100 deciliter, despite optimum statin and non-statin doses or statins intolerance. This is a case from our unit, just to show you some experience of alirocumab that we have had. So this is a patient who was diagnosed with type 2 diabetes in 2001, and by 2003, he had already had coronary artery bypass graft. When the GP had seen the patient, the cholesterol was 9.2, LDL was not measured at the time, and he was treated with metformin and glycoside 160 and simvastatin 40 milligrams and cholestyramine. Cholestyramine is a cholestyramine. In 2002, the cholesterol only came down to 6.5, and 2008 came down to 5.5. And when he came to our metabolic clinic, we recognized that his cholesterol was very high at presentation. So we did a FH genotype and made a diagnosis of FH in this patient. In which case, then we went on to add alirocumab to rosuvastatin 20 milligrams, and then adjusted the doses of diabetes agents, and hypertension was treated with ramipril 10 milligrams. And by the time he came to the clinic in March this year, his cholesterol had come down to 4.6, and he was on the drugs I've already mentioned, plus we had switched his statin to rosuvastatin 40 milligrams. So in conclusion, the strategies for us for very high-risk patients is to treat to goal, but there's a lot of patients who are intolerant to statins, and that we now have agents that we can use to treat these patients to target. Statins have been the primary treatment for significantly reducing LDL cholesterol. However, there's some patients at high risk that cannot take statins due to intolerance or because they can't reach target. Recent studies have shown that PCSK9 inhibitors can effectively reduce LDL cholesterol and improve cardiovascular outcomes in such patients. Adverse events are so far uncommon. Despite the benefits of the high cost of PCSK9 inhibitors may possibly limit their use worldwide, but we are fortunate that we have the National Health Service and we are allowed to use these agents at the moment. Thank you very much, Mr. Chair.